a lot of unconscious techniques that we use to protect our personality. The second key concept, development of the personality. This deals with the stages of development, and we're not going to go into these in a great deal of detail. Just sort of overview these, and I encourage you to read about them more carefully, but basically what we're talking about here is Freud's idea that in childhood we have to meet certain developmental challenges. A lot of the problems that people come to counselors with, relationship issues, trust, and forming relationships, self-esteem, autonomy, and so on, can be seen to arise from this perspective, a failure in development to address basic fundamental challenges or questions at an earlier time in our lives, specifically in this case in our early childhood. And so Freud talked about the psychosexual stages of development, and specifically identified 5 stages, each dominated by a specific challenge in development, and each associated with a particular erogenous zone or pleasure-giving zone of the body. Each stage in the psychosexual stages represents a unique conflict. Each one has a certain conflict that has to be resolved, and if it is not resolved effectively, successfully, then it affects our future personality in a number of specific ways. So, for example, the oral stage, birth to 2, the focus here was obviously the mouth and digestive tract. The challenge here was the need for food, nurturance, and pleasure. So we're hungry, we want food, we want milk, we want to be satisfied. And to resolve this conflict, the issue is developing trust that the world will fulfill your needs and that we can be satisfied. So basically a positive resolution here is ideally when an infant is hungry, then some adult will be nearby and will satisfy the hunger and will help the person to feel better. And when that happens, the person feels basically safe and feels that the world will provide, and they can trust that they are safe, that their needs will be fulfilled. But if things don't go well, then you see fixations develop in later personality. So like people who are described as oral receptive, described as dependent and gullible. They'll swallow anything, they'll believe anything that you tell them, and they want to have things. So they're very focused on satisfying needs, getting information, getting knowledge, and oral fixation. So people chewing on pens and pencils and things like that. And then oral aggressive, people who are aggressive, sarcastic in conversation, and possessive of others. Those sorts of aspects of personality would have resulted from issues at the oral stage. So Freud also talked about the anal stage, next one from around 2 to around 3 years old, which dealt with basically toilet training and control over the bowels. And the issue here was really the successful learning of toilet training and dealing with the control issue. Basically using the toilet when your parents tell you to, or using the toilet when you want to. And problems in this stage, we talk about anal retentive, people who are very orderly and stingy and hold on to things and keep track of things, and people who are anal explosive, messy, sloppy, emotionally and in terms of their physical environment. The phallic stage, ages 4 to 5 years. Focus here was on satisfaction through genital stimulation. People become aware of the presence or absence of a penis, and here the famous Oedipal complex and electric complex are discussed, and the castration anxiety and penis envy, terms that have really sort of come into the popular culture going on at this stage. Not going to go too much into issues with that stage, and then basically the last two, where really less attention has been paid. The latency stage, age 6 to 12, where you experience a decreased or repression of sexual interest. Our energy is more focused on personally and culturally acceptable objects. So we see children moving into a more social period, directing their attention to more social activities during this period. And then the last stage, the genital stage, from 12 to maturity, where sexual energy is invested in friendship, leisure, career development. So you can see at least one issue with Freud's stages is that there's a whole lot of life left after 12, and it's sort of all wrapped up into this one stage, genital stage, from 12 until the rest of your life. And that's one of the criticisms of this developmental theory, this approach, is that it doesn't really address in any detail what happens after the teen years, for example. Other criticisms are that it's hard to test these ideas using the scientific method. It's hard to research these ideas. These ideas have been criticized as being based on the male-dominated culture of the Victorian era, and I think most people would agree that that sort of bias is evident in the terminology and the ideas, and it was not actually based on, these stages are not based on really observational work with children, but talking to adults who had emotional difficulties. So in this theory, in psychoanalysis, I think this area in particular is where I think people tend to have the most difficulty. Erik Erikson, on the other hand, developed this series of stages of development called the psychosocial stages of development. Again, not going to go into these in detail, but just point out that there were and obviously are many other approaches to where people have paid more attention to actual development of the child and what was happening really throughout the life as well. So Erikson came up with 8 stages where an individual confronts challenges, conflicts that have to be met in order for healthy development to occur. Erikson emphasized that the continual process of personality development takes place throughout the person's life, and there he is, Erik Erikson, and his wife Joan. Erikson lived from 1902 to 1994, but basically in terms of the psychosocial stages, Erikson and Joan, who worked closely together, suggested that conflict and tension are the sources of the growth that comes out of living, growth, strength, and commitment. So positive consequences of dealing with these various issues. Again, not going to go into these in great detail, but they include the trust versus distrust, autonomy versus shame and doubt in early childhood, initiative versus guilt, industry versus inferiority, identity and role confusion, intimacy and isolation, later on moving into adulthood, generativity versus stagnation in adulthood, and then later in life, ego, integrity versus despair, and then finally, much more recently, Joan Erickson has suggested a stage, people in their 80s and 90s, people at the very sort of extremes of aging, dealing with another conflict termed disgust and wisdom. One other example of developmental stages from also from a psychoanalytic perspective. Okay, key concept 3. So putting together some of these ideas in terms of the goals of therapy, psychoanalysis, putting together the pieces of this puzzle. And in general, what we're saying is that the problem that we deal with in psychoanalysis is neurosis due to blocking or defense against or distorting of reality. So problems in dealing with reality lead to neurosis, and the process of therapy and psychoanalysis is to uncover the unconscious, deal with it in the conscious, experience emotional release, healing, and integration. We do this through the process of, first of all, making the unconscious conscious, so bringing some of these unconscious issues into awareness in the present, strengthening the ego, so working on strengthening the personality so that the behavior is based on reality and based on awareness and less on instinctual cravings and guilt. And then third, a self-understanding through insight, or becoming aware of our symptoms, of our neurosis, and the purposes that they serve. So psychoanalysis is really about bringing the unconscious into conscious awareness. And Freud developed a number of ways by which this can be done. Routes of bringing the unconscious into conscious awareness. And I remember at the beginning I mentioned that he began sort of thinking about this when he was working with Charcot and the hypnosis idea. The idea that hypnosis took away the filters, the inhibitions, and allowed people to express themselves freely and talk about those traumatic events. It was a very important idea to Freud. And what he did, again, he didn't do hypnosis. He doesn't talk about hypnosis in psychoanalysis, but he does use another approach that does the same thing. The free association, the blank screen idea, which is that the person sitting on the couch, instead of facing the therapist, is able to speak without filter, without worrying about the social interactions, without looking at the face and seeing the responses and the nonverbal communication, but just is able to talk freely and put ideas out there. Another route is the process of dream analysis, and the idea here is that when we are asleep, in our dreams, the ego can relax and doesn't work so hard to prevent the id from accessing consciousness. So the id is free to express itself, a little bit more free to express itself. But the ego is still working a little bit, and basically these impulses and urges that are going to make us uncomfortable, the ego disguises these and distorts these by basically reframing them, putting them in another context, or using symbols to represent them that are less threatening. So Freud developed a whole really lexicon, a whole language of these symbols and what they mean in dreams, and talked about that in that book, The Interpretation of Dreams. And certainly dream analysis is a process that psychoanalysts use to help the person bring the subconscious into conscious awareness. Projective techniques, like you're probably familiar with, for example, the Rorschach ink blot test. These are techniques where the patient or client is presented with an objective, meaningless stimulus, and what we're interested in is how they respond. What are their reactions to this thing that could be anything? So the ink blot test, for example, really could be anything. The image that you see doesn't really matter so much as what's important is how the person sees it, what they see, what they describe, and then what the analyst, how the analyst interprets that, and what it tells us about what's going on subconsciously in the person. And then another route to the unconscious is the idea of transference, which means the reactions of the therapist to the client or patient with whom they are working. The therapist realizes that the patient is having an emotional reaction, response to the therapist. Basically, the patient or client starts talking to the therapist as if they were an important person from their past. Sort of emotional reactions that aren't appropriate or don't seem congruent with the context, and don't really make sense. And you get the sense that the client is reacting to not to the therapist, but to somebody in their past, some previous relationship, and working out that issues in that prior relationship are a process of, again, accessing the unconscious, accessing things that are going on underneath the surface. Okay, you're probably aware that the process of a psychoanalysis proper, the way it's professionally done, is a process involving usually years of work. Patients see a psychoanalyst 2 to 3 times a week for sometimes several years. Obviously, that sort of approach isn't going to work in counseling in the age of managed care, where we get 8 sessions, for example. And it's not going to work in the rehabilitation counseling context, where our relationship time also tends to be limited and our goals are very focused. So we're not talking about using psychoanalysis in rehabilitation counseling, but can you do counseling and rehabilitation counseling from a psychoanalytic perspective? And obviously some people believe that you can, and the idea is that the goals are the same. So you would be working to increase awareness and insight into behavior, trying to have the person have an emotional release and develop understanding of the personality, and all those sorts of goals that we talked about in psychoanalysis are basically the same, but the techniques would be different. So you probably wouldn't use the couch and the chair. There are changes. There are things that we would do differently within the limits placed on counselors in terms of time and issues that are being dealt with. But some of the techniques that can and are used in psychoanalytic counseling, for example, counselors still use free association. Don't use the couch, but still use the technique, where clients would be encouraged to say without filter whatever comes to their mind. Report thoughts and feelings and associations. You would still do interpretation of resistance and try to understand the meaning of the process. You could still do dream analysis, analysis of transference. All those things would still work in the short-term counseling experience, but it is a more active and directive approach. The counselor is much more active in the process than would be the case in traditional psychoanalysis. What about in rehabilitation counseling? Again, very few rehabilitation counselors identify themselves as psychoanalysts or as even using a psychoanalytic approach. But as I said at the beginning, a lot of ideas from this perspective have been important in rehabilitation counseling. The defense mechanisms have been studied and applied in the context of coping and adapting to disability. The idea of body image and the relationship between body image and self-concept. A lot of research in that area, and the idea there is that as the body changes in as a result of or along with disability and chronic illness, so does the identity of the individual, and adaptation or adjustment to that, to the changes in the body image, involve changes in the identity and coming to terms with basically the development of a new identity. A lot of psychoanalytic ideas have also been applied to understanding attitudes about disability and towards people with disability. A lot of research in that area, and a lot of ideas come from the psychoanalytic perspective.